So let's start with NRHM and overview. Specifically in the view of the achievements of NRHM, it's got another 5 years extension term. But how do you really, in terms of ground realities, assess the work done so far? Are you happy with the progress made?
Well, I'm very happy. And of course, the size of the country is huge, and it is one can never say that whatever we do and is perfect. So to have a perfection with the size and population of a country and uniform perfection is always very difficult in our country. But by and large, I can say that this NRHM has brought revolution in our country. In spite of the fact that health is a state subject, and since the federal government in 2005-06 chipped in, it has made I think a lot of difference in the healthcare, because our objectives since we launched this national health mission was to strengthen the the infrastructure of the country, and we also wanted that affordable drugs should be provided to our countrymen, particularly those who are poor. So I can say that today we have almost 25,000 new hospitals. I'm not talking about the big hospitals and AIMS and all that. I'm talking about the rural area, district and below. About 25,000 hospitals have been newly constructed, and as many as 25,000 have been augmented. So total 50,000 hospitals in just 9 years' time is a big.
So if we talk about the state of hospitals, the government hospitals specifically, we know that the center is doing much in terms of providing money, but the fact of the matter is that in terms of infrastructure, in terms of medical facilities, I'm specifically talking about state of government hospitals. Don't you think a lot needs to be done there?
Yeah. No, first of all, the infrastructure was inadequate. That was not in proportion to the population. Maybe whatever hospital, district hospital was constructed 40 years back or 50 years, and 40 years back the population was 1/3 of the population what we have today. So it was not augmented. Some hospitals were constructed about 60 years back and no new construction had come up. So we had to construct afresh. So I think one of the biggest thing has happened, that at least the augmentation of the infrastructure has taken place, and the new hospitals have been created. So first is the infrastructure.
Right.
That is most important. And then second part is the human resource. So human resource is totally inadequate, because whatever we have, whatever number of doctors we produce, few of them leave, they go to other countries. You will be surprised that in United States of America, the registered number of doctors, which I happen to address them, is 61,000. And those who are not registered, they are another 20 to 21,000. So in United States of America alone, the doctors of Indian origin are about 81 to 82,000. Similarly, in UK, the doctors of Indian origin are between 70,000 to 75,000. When we talk about the Gulf countries, the number is again 50 to 60,000 countries. And there are smaller countries in Australia.
But they're better off in terms of doctor-patient ratio.
So that's why we are suffering. And then we have another problem. The problem is not in the southern part of the country and the western part of the country, because almost 75% medical colleges are located in private sector in the southern and western part of the country. And it is also the government, most of the government colleges are also located in the southern and western part of the country. So rest part of the 2/3 part of the country, that is central India, northern India, eastern India, northeastern India, we have very few government medical colleges and we have very few private medical colleges.
So are we doing something in a direction?
No, we have done, I think, in the past 4 years, because this is one of the areas which I identified as Health Minister and Chief Minister in Jammu and Kashmir, that unless we bring some change, unless we increase the human resource. So that's why the first priority after taking over as Health Minister was to change the rules of the Medical Council of India, to rationalize the land use. Earlier the land use was huge, but now When this Medical Council of India was conceived, that time in 56 there was no dearth of the land. So land has been reduced. The buildings have been reduced. Size of the building, almost 25% capital cost has come down. So it has been made more attractive to set up a medical college. Then there was a cap, irrespective of whether it's a private medical college or a government of medical college. The intake for a graduate, that is for MBBS, was fixed at 150, irrespective of the size of the building, beds, and the number of the faculty you have. So that has been capped at 250 instead of 150. So as a result of which, the more intake of undergraduates. Now we had, now a lot of private sector has come up during this period, and whatever number of doctors or specialists, super specialists we had in government sector, they moved most of them to the private sector. As a result of which, we didn't have the faculty in the government medical colleges. We didn't have the the specialists and super specialists in the private, in the government this hospitals. So to overcome the shortage, we took 2-3 decisions. First of all, the student teacher ratio. The earlier student teacher ratio, that means a professor and an additional professor could only teach one MD student, irrespective of the stream. One professor for cardiology will teach one, oncology one, neurology one. So that we changed, that one professor can, or additional professor can teach 2. And in some critical areas, one professor can teach 3.
Okay.
So as a result of which, the number of the seats in PG have increased almost by 70%. So this is a huge, just with one stroke policy decision, the number has increased.
Intake of students obviously must have
and
gone.
Most of the medical colleges were, new medical colleges were not coming up because there was a shortage of faculty, teaching faculty. So we took 3 important decisions to increase the faculty. You may have a money to set up a college, but you can't, with money you can't produce a faculty. So to increase the faculty, we did 3 major things. First of all, we increased the age of the faculty through Medical Council of India from 58 to 70.
Okay.
So it's a huge. So now people will not retire, so you have availability of the faculty with you. Similarly, we recognize the degrees of 5 English-speaking countries. The degrees, postgraduate degrees and MBBS degrees of United States of America, Canada, UK, Australia, and New Zealand. So these are I recognize. So people can come from there and be a faculty. Similarly, DNB could not become the faculty member. So we recognize also that DNB can be a faculty. So I think this is also to how to increase the faculty. We have taken these steps. How to increase the MD seats. We have done 1:2, 1:3 student ratio.
Right.
So that has taken.
जो जाएगा वो वापस जरूर आएगा। अगर आपके पास होम इंश्योरेंस है तो कर लो इंश्योरेंस, कर लो रिवाइंड।
मैं शपथ लेता हूँ कि 18 साल से कम उम्र की लड़की को अपना जीवन साथी नहीं बनाऊंगा,
ताकि मेरा होने वाला बच्चा कुपोषण का शिकार ना बने।
18 साल से पहले लड़की शारीरिक और मानसिक रूप से मां बनने के लिए तैयार नहीं होती। ऐसे में उसके होने वाले बच्चे को कुपोषण का खतरा रहता है। इसलिए 18 साल से पहले अपनी लड़की की शादी हरगिज न करें और कुपोषण के खिलाफ इस जंग में देश का साथ दें।
ये प्रेजेंटेशन में ऐड कर लेना। बाकी अगर कोई बात करनी हो तो मुझे फोन कर लेना। हाँ, cheer up बेटा, तुम्हारी इलेक्ट्रॉनिक डॉल और बड़ा सा टेडी बेयर दोनों तुमको मिल जाएंगे, लेकिन एक कंडीशन है, अगले एग्जाम्स में अच्छे मार्क्स ले आओ।
वो तो मैं लाऊंगी पापा, पर मेरी भी कंडीशंस है।
अच्छा, वो क्या?
पहली ये कि ड्राइविंग करते वक्त आप मोबाइल पर बात नहीं करेंगे, और दूसरी ये कि आप हमेशा अपना सीट बेल्ट पहनेंगे, और तीसरी ये कि ड्राइव करते समय आप सामने की ओर ही देखेंगे।
ओके बेटा, मैंने तुम्हारी सारी कंडीशंस मान ली।
बच्चे भी हो गए सयाने, अब तो आप भी ट्रैफिक रूल्स माने।
Getting back to the nitty-gritties of NRHM, that's from where we really started. But what are the what are the stringent steps in terms of containing the irregularities in the NRHM? Because, for example, UP NRHM scam, how does your ministry really keep a check on that?
Well, it's very difficult. I must admit,
You
it's
agree?
very difficult. It's very difficult. As I said, that 50,000 constructions going on across the country, whether the new constructions or augmentation. Yeah, if I have to oversee this, the construction of these buildings, that means I need at least for one building, one person, that means 50,000 people. And then my whole budget has to be spent on the supervision. So that I cannot do. And whether each children or child has been immunized, you know, few crore children have to be immunized, is very difficult. Of course, we have done, like immunization. We were not sure till I took over. It was haywire. You will get just lump sum number, so many percent. UP has done so many percent. Bihar has done so many percent. Kashmir has done so percent. There was no name. Who's being vaccinated or who's being immunized? No name, nothing. So the first thing now we made mandatory. We don't accept any states just lump sum number. It has to be whatever number has to be sent by them. It has to be name based, address based, and telephone based. So telephone of the parents of the newborn, address and phone. And we have set up a BPO in my ministry the first day at the time of the launch. And we have a team of boys and girls.
And financial irregularities, sir?
The financial, again, you know, our job is to provide the money for a specific purpose. We provide to the states, high focus states, we provide about 33% for the infrastructure, and for low focus states 25% for the infrastructure, and the rest are for the health care system. Then it is for them, you know, lot of we give the money also procurement, for money for the procurement. So whether that is really spent or not. So it lies on the interest, how much interest the state governments have, and whether you have people of impeccable integrity and honesty. That is for the state governments to see.
Let's now talk about a couple of your schemes, specifically ASHA and JSSK. First up, ASHA. How do you, it's been really talked about a lot in terms of this is one of the most prominent faces of NRHM, and it's really, really penetrated well as far as rural areas are concerned. But then what are you doing in terms of its expansion, specifically when we talk about hilly areas, deserts, tribal zones, and also the northeast stretch of the country?
Well, I think the Ashas are the only one who are almost in each village. And not in each village, in tribal areas, in difficult areas, in accessible areas, hard to reach areas. We don't mind. Of course, the basic purpose was to provide one Asha on 1,000 population. But that would have given us hardly 700,000. Now we have crossed 860,000 Ashas. That means we have in tribal areas and hard to reach areas, we have gone even beyond 1,000 population. So at least I can say now each village, and I happen to visit different parts of the country, in hilly areas also, where I land by helicopter, I come across the Ashas are there. So I think this is one of the greatest link between the pregnant women and the health facilities. That is besides the point that in rural areas where you do not have the road connectivity, whether these Ashas are able to make some difference at the time of the delivery, because Ashas while providing the medicine, iron, folic acid during the pregnancy. At the time of the pregnancy, these ashas are supposed to take the pregnant women to the government facility. Well, in hilly areas, in tribal areas, where you do not have the still road connectivity, in spite of the fact that the government of India has done extremely good also in providing connecting each village, but some villages are yet to be covered. The road has not reached there. So in those areas, in spite of our program, it is difficult for them to carry a pregnant woman on the horse's back or on the back of some person and to take. So such areas are still difficult.
Sir, and also, Asha, when we talk about it, it's beyond healthcare in terms of educating, in terms of empowering. Ashas also, I mean, they also belong to the same area. And the skill development.
But skill development is the one of the basics. And unless skill development, you can't just expect a village girl to know about all the intricacies of the health and all that. So we have different capsules, training capsule, first, second, third, fourth, fifth. So by and large, almost more than 700,000 ashas have been trained. And they have reached from fifth capsule to the seventh capsule. So that's an ongoing program. Whatever new program we might launch, for that new program is a new training capsule for that. So it is not that they are totally raw. Sometime I get, the delegation from different parts of the country. Of course, they have their own problems. They want salary to be increased, incentive to be increased. Then I cross-check them. I just take them, want to know whether they know something, and they definitely know. And few of them I was surprised, as are hardly primary pass, but they know a lot of things about.
Sir, in JSSK, in one of your interviews earlier, you said that in fact it really it's revolutionized the healthcare sector. But do you really think, in terms of free entitlement reaching to the last poor, how do you really ensure the implementation bit?
Well, JSSK, Janni Shishu Suraksha Karyakram, which was launched by Mrs. Sonia Gandhi in September 2011 from Rajasthan, from Mewar district. Almost 60,000 women were there when we launched this program. It has been very, very successful. I must say there are states which have implemented it to the extent of 106, 110%. Again, as I said in the beginning, it is not uniform. It depends on the minister concerned, the state government concerned, the chief minister concerned, what type of mission director you have, what type of health secretary we have, and what type of continuity you have. Now, like in Delhi, well, I stuck to my portfolio. I must thankful to both Mrs. Gandhi and Prime Minister. I told them that I would like to be here complete 5 years, because if somebody comes, it may take him some time, how so efficient he or she may be, but the one who conceives the child, he can nourish child much better way than the adopted mother. So what is happening in the state governments, in the most of the state governments, the frequent changes of the ministers, the frequent changes of the secretaries, the frequent changes of the mission directors.
That's an obstacle, sir?
That is a
major
great obstacle.
challenge.
There's a great obstacle. Well, I must thank the Prime Minister and Cabinet Secretary that whenever there are officers change in my ministry, I tell them that I cannot take somebody from Congress, from commerce or agriculture or food processing, who it will take at least 1 year to understand IMR, MMR. So I would select those people who have worked as either they are working as the health secretaries in the states or have been health secretaries 2 or 3 years back. So that gives me an added advantage. Last year I had almost 10 joint secretaries have gone, but they have been replaced by the secretaries who have been either sitting health secretaries or ex-health secretaries, maybe from down the line. So it didn't take them time to understand. So what is happening in most of the states where we suffer, that the frequent change of ministers.
Like states
no,
like?
I won't like frequent change of officers, and that is also, and here you need a continuity. You need a continuity. So some states were, and this GSSK, as I said in the beginning, this is one scheme. Nowhere in the world, in rest part of the world, they might be providing free diagnosis, free food, free consumables, free medicines during the hospitalization to a pregnant women, but there's no guaranteed, provision of transport prior to, delivery and post-delivery. That is guaranteed. And for that we have provided as many as 18 to 19,000 ambulances. And the JSK, that was JSY, but the JSK further provides that if the government fails to provide a government facility, ambulance, or they are not able to get, you don't have the government facility to transport, they can come by private transport, and that will be reimbursed by the hospital. And from my ministry, we provide that money to the state government in advance by 1 year, to provide that money with the hospital 1 year in advance, so that no hospital should say that I don't have the money to provide the the transport which you have incurred too. So that's a great revolution. And now from this year we have brought another revolution. The earlier JSSK was that pregnant women will be brought, either she can come by private transport, that will be reimbursed, and after delivery she can go back by private transport, that will be reimbursed, or she can be brought and go back by government transport, ambulance. And during her stay in hospital, the food will be free, diagnosis will be free, consumables will be free, medicine will be free, cesarean will be free. And now we have made an additional change during antenatal care. That means during pregnancy, if she develops some problem, she can come to the government hospital, either of her own or through ASHA, for as long as she is not recovered, she will be provided free medicine, free diagnosis. And postnatal, after delivery, if she gets some complication, earlier the provision was only up to maximum 7 days. Now for 45 days she will get, after delivery also, free treatment if she develops any problem. Similarly, for the newborn child, earlier in JSSK, since 2011, under the JSSK, for the newborn child, the consumables and medicines, which are very high cost. I mean, for a newborn, the medicines are very costly. The provision was to provide free for 1 month. So now we have increased it for 1 year, free consumables, free medicines. So the question is, first I think we need awareness, that's most important, and very active state administration, health administration, very active state health participation, and very active implementation.
States need to cooperate.
They have to not cooperate, they have to rise to the occasion.
प्रियंका भारती? हाँ। ए शारदा, विमल, हरिया, सब इधर आओ। ये प्रियंका, बहुत नाम है इनका। अपनी इज्जत और स्वच्छता की खातिर अपने लगन के दूसरे दिन ससुराल छोड़ने की हिम्मत दिखाई और अपने मर्द से शौचालय बनवाने की मांग की। सुना उसने? जब सोच और इरादा नेक हो तो सब सुनते हैं, जैसे इसके मर्द ने सुना। शुरू करें निर्मल भारत अभियान। आप भी अपने घर में शौचालय बनवाएं और इस्तेमाल करें। जहाँ सोच, वहाँ शौचालय।
अरे गेट खोलो। अरे भाई, टॉर्च क्यों मार रहे हो? दिखता नहीं कौन है?
माफ करना साहब, आपकी हाई बीम ने मुझे अंधा कर दिया, इसलिए चेक करना पड़ रहा है। मैंने देखा है कि लोग हाईवे पर हाई बीम का इस्तेमाल करते हैं, लेकिन साहब आप तो कॉलोनी में ही।
सॉरी। हाँ,
लो बीम पे चलें, सेफ चलें।
अरे सुन तो।
मुझे क्या सुनाना चाहते हो? जो सुनाओ मेरी सौतन को।
किसको?
अरे वही तुम्हारा मोबाइल फोन जिससे सुबह शाम दिन रात चिपके रहते थे और कहते थे किसान कॉल सेंटर से बातें हो रही हैं।
अच्छा ये बात है।
हाँ, क्यों? क्या हुआ? अब बात नहीं होती क्या?
अब तो झट से बात हो जाती है।
ऐसा क्या?
हाँ, अब तो ज्यादा लाइनें और खास तकनीक के कारण खेती के माहिरों से तुरंत बात हो जाती है। और अगर कभी लाइन व्यस्त हो तो अपनी समस्या फोन पर रिकॉर्ड करा दो, वहाँ से फोन आ जाता है और समस्या की हल का मैसेज भी आ जाता है। ये देखो आ गया।
अरे वाह, इसका मतलब इंतजार की घड़ी अब खत्म।
हाँ,
तभी मैं सोचूं कि आजकल मुझ पर इतना प्यार क्यों आ रहा है।
कृषि संबंधी समस्याओं का अपनी भाषा में तुरंत हल पाने के लिए पूरे भारत में किसी भी फोन से हेल्पलाइन नंबर पर संपर्क करें। किसानों का दोस्त किसान कॉल सेंटर।
So, final word now, since you said that states need to rise to the occasion without the help of state, without them really coming on board with you, it's not possible. When we talk about the universal health coverage, which UP has been really talking about, really see it becoming reality, because the fact of the matter, Honorable Minister, is that we still have a very poor doctor-patient ratio. I mean, 1:2000, if I'm
well,
wrong,
I won't say not only 1:2000 in some states. I would not like to mention is 1:4000 also.
Okay.
So 1:2 becomes a average.
So having said that,
so,
sir, universal health coverage, when it will become a reality?
So far, I have done our bit, my bit, to increase the human resource. That I said in the beginning, to make it more attractive to set up a medical college, whether it's a government sector or private sector, rationalize the land, rationalize the construction of a building, brought the construction down by almost 25%, increase the intake of the students for the undergraduate, made the student-teacher ratio increase from 1:1, 1:2, 1:3 for the PG graduate, to set up more medical colleges to overcome the shortage of the faculty, increase the age of the faculty, allowed the recognize the degrees of 5 English speaking countries, so that should anybody like to come here to teach, they are free to teach. DNB degrees have been recognized to become the faculty members. So these are all the initiatives which we have taken at the federal level, at the central government level. Now it is for the state governments to set up more medical colleges in the government sector, to convince more in their respective states, those who are well-off people, to set up more medical colleges. And unless we have almost double the medical colleges, we have as many as 362 medical colleges at the moment, and 672 medical colleges have come up in the last 4 years only. I am hoping at least 15-20 more medical colleges in this year within the next 2-3 months. But ultimately, this is a subject, this is not like defense, finance and railway, that we can do everything centrally. This is a state subject. I think we have already walked not extra miles, few extra miles, which
and you need these states to walk with you as well, obviously.
Now they have to keep pace with us.
Thank you very much, sir, for talking to me.
Thank you very much.
Thank you. Pleasure.